and welcome to our webinar, The Future is Hot, Advocating for Climate Resilient Communities. Before we begin, all of us at the Medical Society Consortium on Climate and Health respectfully acknowledge that our advocacy, education, and learning across the country takes place on the occupied and unceded lands of many Native American tribes. To acknowledge this land is to recognize its long history and our place in that history. It is to recognize these lands and waters and their significance for the peoples who live and continue to live in this country and whose practices and spiritualities were, are, and should always be tied to the land and the water. We respectfully acknowledge our debt to the labor of many peoples who contributed to the building of this nation. We acknowledge the enslaved people, primarily of African descent, whose labor and suffering built and grew the economy and infrastructure of this nation, and that slavery's ongoing impacts are still felt by countless people. We also acknowledge our collective debt to the indigenous peoples of this land whose labor was forced and exploited, the Chinese immigrants who built railroads that allowed for westward American development, Japanese Americans whose properties and livelihoods were taken from them while incarcerated during World War II, and we recognize the immigrant and American-born workers of African, Asian, and Central and South American descent whose often unseen labor has and continues to contribute to the well-being of our collective community. Today's webinar is the second in our 2025 Climate and Health Equity webinar series as part of the Climate and Health Equity Fellowship Program. The CHEF program recognizes the need for more climate and health leadership and a sharper focus on equitable climate solutions. The goal of the fellowship is to educate physicians from populations that face greater burdens from climate effects and are underrepresented in medicine to become leaders in climate and health equity education, advocacy, and policy solutions. I'm Dr. Shanita Johnson, Director of the Climate and Health Equity Fellowship. Also joining me from the consortium to run this webinar are Dr. Venice Curry, Associate Director of the Climate and Health Equity Fellowship, Dr. Kimberly Williams, Director of Operations and Strategy at the Medical Society Consortium, and Clarissa Payton, CHEF Program Assistant. Clarissa will also be available through the chat to answer any technical questions during the webinar. The webinar series is hosted by the Medical Society Consortium on Climate and Health. It is held for 1 hour on the second Friday of each month from 3 p.m. to 4 p.m. Eastern Time. Today's webinar will be recorded and made available on our YouTube channel and website for future viewing as part of the Climate and Health Equity webinar series page on our website. We know that many parts of the country are already experiencing above average temperatures, and it is essential to understand the health risks associated with climate change, particularly heat-related illnesses. Today, we are honored to have an expert in this field, Dr. Christopher Uejio, join us. He is a professor and director of geography graduate programs for the Department of Geography at Florida State University. He earned his doctorate in environmental studies from the University of Wisconsin-Madison, and he studies how the physical environment, broadly defined, influences human health and well-being. He co-authored the Centers for Disease Control and Prevention's Building Resilience Against Climate Effects, or BRACE, framework, and frequently works with health departments to understand and adapt to climate change. But rather than using our time to provide a further description of his impressive work, we are placing a link to his bio in the chat. The general format for today's webinar will be one 35 to 40-minute presentation followed by Q&A from our audience. We ask that you put comments, links to any resources that you may recommend, or any questions that you may have for Dr. Uejio in the chat box at any time during this presentation. We will get to as many of the questions as we can during the Q&A period. Please also keep yourself muted so we are not interrupted by background noise. Dr. Uejio, you may begin.
Thank you for that wonderful introduction. And thank you for inviting me back. That's always a nice sign that at least what I was doing was quasi-palatable. Great. Okay, hi folks. Feel free to call me Chris. Advocating for climate resilient communities. I'm doing a bit of a deeper dive, I guess, into extreme heat today. But a lot of you, I recognize, might work on this issue as well. I'd love to make this more collaborative and a shared learning experience. And I'm not a medical doctor, so there's tons of that I can learn and that we don't know about some of the physiological effects of heat. But I'm going to take sort of like a bigger picture viewpoint of it. Okay, I want to just talk about brace for a minute. Brace. There, I know the federal government is filled with acronyms and then transition to extreme heat. But the Building Resilience Against Climate Effects, or BRACE framework, is a five-step framework. The framework was actually being retooled. I mean, I guess I have to put the downer side of the downsides of it up front. The entire program, okay, almost all the entire program staff was let go along with the other Division of Environmental Research and the Centers for Disease Control and Prevention. So they are currently on administrative leave, obviously hoping that they are brought back to work. So this grant program is still technically going, but the is in doubt for it's fair to say it's in doubt for the 2026 to 27 year point. But nonetheless, I have to say a bit about it just because yeah, even in periods where I might be mourning it, there's still some lessons or things. As a rule of thumb for my own work, if the longer we ignore a hazard or a risk, the worse it gets, the more we're going to have to deal with it later. So in other words, it's not going away. Okay, so yeah, so big picture, the CDC Brace Framework, Climate Ready Cities and States Initiative, at the time was actually, sorry, can you still see my screen? Sorry, can you folks still see my presentation screen?
Yes, we can see it.
Sorry about that. Sometimes I was fiddling with the screen. Anyway, so at the time was actually the only appropriation under the Obama administration that was new money for climate adaptation, which I know is kind of mind-blowing, given that the previous administration put a lot more, but certainly not commensurate with the need into the field of climate change as a whole. But really, under the Obama administration, there was really only one new climate adaptation program, and it fell under health, which was nice. So the states here, not all of them are actually all currently grantees, but the blue ones are those that were currently or previously funded. In essence, there's about 11 of them, mostly states, since in the United States, as you know, state public health works kind of hierarchically from the federal one to the state to the counties, um, and in sort of in partnership with cities. There's a few cities that have special exemptions that can also apply for their funds directly. So there's about now there's about 14 of us. To be honest, I don't know what's going to happen next. I just am sending an email to them to there's a bit of a leadership vacuum, so I'm stepping in to just convene everyone to just talk. Okay, so what is the BRACE framework? As I mentioned, it was in the process of being retooled, and it actually I'm going to present the old framework because the new framework wasn't formally adopted and includes some of the censored language, to be quite honest. So the old framework, which although dated, is still a decent roadmap to how to address vulnerabilities to not just extreme heat, but other climate hazards in your community. So step one, just for the locations of those people who are at risk. So you might have historically done this with EJ Screen and the Environmental Justice screening tool, which is no longer available from the EPA. You might have done just with this accumulative environmental justice index. There's many ways one could do this, social vulnerability indices. And while these data sources may not be available, some of them are archived. I'm happy to talk about that. Or there are packages and ways to reproduce them with not as much effort as one might think. And so in the context of heat, here, just as for examples map, we've done a study just mapping who has access to air conditioning in Florida. And you might think, yeah, a hot and humid place like Florida, everyone has air conditioning. That's generally true, but not completely true. So in our big metropolitan cities, maybe 3, 4, or 5% of the people do not have air conditioning. In rural areas, that number might be as high as 10 or 15 or 20% of the people. And then that just says nothing about those who can't afford to either repair it or pay for the electricity to use it, right? So just get in at first cut, but we know it's in reality things are more complex. So step 2 out of 5 of the BRACE framework, just what are things going to, we know climate change is happening now and it's having a diverse impacts on health. What is going to happen in the future? So to do that, we use a convergence of evidence. We use observations, we use theory, and we use models. So observations, have things gotten hotter now? You can know from your own lived experiences, yes. Models, we can use climate models, which essentially have mathematical equations to project in the future to say if we change the energy budget, how that by adding more greenhouse gases, increasing the thickness of the greenhouse gases, or the blanket, if you will, the virtual blanket that warms up our planet, it's going to continue to get hotter. And then theoretically, there's some reasons why. It's not just that temperatures are going to rise, there's more energy going into the Earth system as a whole. A lot of that's actually going into the ocean, but the energy that doesn't go to the ocean goes onto the land surface. And then there's this feedback where we essentially have drying out, particularly in the southwestern or western part of the United States, of the soil moisture, and you might actually get further make heat hotter. The heat exposure is higher. So some of these I'm just going to reference in passing. I apologize that, but some of them may not be as comprehensive as you'd like, but please feel free to ask me questions. So third, step 3, what do we, is really what public health departments like. What can we do about it? We know there's a problem. We know generally where people are suffering from it. We know when it's happening and if it's going to get worse. And then 3, what can we actually do? And that I think does overlap a bit also with the clinical sides of the field as well. When you're seeing patients, referring them to social services, things like that. So this is just a campaign I've worked with Miami-Dade County on a bit, which I think I'll circle back to at the end. And then obviously not just do we do one thing, can we come up with a suite of interventions to holistically address? In this case, my talk is focused on heat, but really we need a plan for climate change and health more broadly. So this is Miami-Dade's. I worked with Jane Gilbert, the world's first chief heat officer in Miami-Dade County. Jane's retiring this month and that office is closing, is being merged. But nonetheless, they've done some really good work on coming up with an evidence-based extreme heat response plan. And then obviously you want to evaluate what you're doing and improve on that quality over time. Okay, so I don't want to be all negative, right? So I have to, like, where is I keep it real, but like, where is, if there is hope, I need to at least talk about it. So just to throw it out there, one of the world's leaders, not just the United States, but the world's leaders in addressing extreme heat is Maricopa County. So that's the city of Phoenix and a variety of other cities in Maricopa County. But also has the world's second chief heat officer, but Dave Hondula is an old colleague of mine. But essentially, they were able to start bending the curve. So they still have a seemingly huge number of people who die of classified extreme heat related illness per year, around 700. But they're one of the few places that has started to bend the curve. Is that, are the evaluation activities are still being conducted? Is that completely due to our propositive efforts? Maybe not. But nonetheless, at least we're starting to see progress there on some of these key outcomes. Okay, I'm going to move on to extreme heat. And this one. So how many people die of extreme heat in the United States per year? If you don't mind, I'll take a moment to see if you can put it in the chat. Just to try to make this a little bit more interactive. Or you can just shout it out too. I don't, that's great too. So the official number, if you ask the CDC, they'll say is something like 600 to 1,000. And that's going to be those that are noted on coroner or medical examiner or justice of the peace death certificates, right? But obviously that's an undercount. Yeah, so 12,000, but even that, so for a while, I'd always questioned our numbers, the scientific community. And for a while, I thought 12,000 might be too high, but I actually don't. I think that's, if anything, it's still conservative. So that's estimated using sort of statistical techniques applied to excess mortality. So these are sort of heat exacerbated or heat contributed deaths. So why would I think that? It's just, for example, if there are 700 in Maricopa or Phoenix that are conservatively ascribed to heat, Las Vegas has about 700 or 800, but we can start to easily get up to 12,000 just in the Sun Belt alone. Okay, who's at risk for extreme heat? Again, many of you might know this, but just so we're on the same page, older adults, as we age, and just like our immune systems get weaker, also as we age, our ability to thermoregulate decreases. So essentially, older people store heat longer in their bodies. Infants, children, and pregnant people, for a variety of reasons, like children tend to be smaller, they heat up quicker thermodynamically, they may not be able to communicate as easily. Infants and pregnant people, there's a large and growing literature showing that sort of in utero, exposures to both just high temperatures as well as heat waves, these sort of like shorter periods of intense extreme heat, lead to preterm birth, small for gestational age, a variety of adverse birth outcomes. And chronic conditions, obviously a bit tied up with older adults, are more likely to have chronic conditions. To some of those might directly have pathways to extreme heat, but as many of them also are indirectly through the medications that people take to manage those chronic conditions might increase your heat sensitivity. Some antipsychotics, some other antidiuretics. Low income and unsheltered or unhoused people, as we were sort of hinting at, if you're not able to pay for electricity, you're more likely to suffer from extreme heat exposures inside your house. So broadly, surveys suggest maybe like 12 to 16% of people have to make these sort of impossible choices between paying for food or paying for electricity. And when things are getting more expensive, it's making things even harder. And then from there, people who work or exercise or recreate outdoors. So a wide swath of people, in short, in which case sort of the policies that you would choose to address that might vary. Okay, this is just a snippet just from our work. I know I've totally skipped the study design, but this is just the odds ratios for two groups: those who did not report a social security number and those who did report a social security number. So we've compiled some of the first evidence in Florida, well, in the nation, really, but it suggests that in general, people who do not have a social security number and therefore potentially undocumented versus those who do generally have the same heat risks. And that might make some sense. But in a place like Florida that does have some large agricultural regions, also some large metropolises with construction industries, we do find on average there's a slightly elevated risk in this case. I think for dehydration and cardiovascular, I think I'm just showing you dehydration related emergency department visits than those who do report a social security number. Okay, so how does extreme heat impact the body? Again, I'm going to largely defer to you folks, but broadly, as you know, we're warm-blooded. We have to keep a consistent body temperature. Evaporative cooling is the most energetically effective way to do that. So essentially, the ability to sweat, particularly in a dry and hot climate, is energetically the most efficient. If you're like me and you live in a hot and humid place like Florida, that's where things become a little bit dicier. Essentially, you have to just rely, your body has to rely on conductive heat loss. So essentially just increasing more blood flow from your core to your skin to conduct heat away from the body. That obviously is going to put some more strain on a variety of your systems, obviously cardiovascular systems, but also the volume of blood, the viscosity of the blood increases. Respiratory disorders is also fairly well categorized, or sorry, fairly well documented on the epidemiological side, meaning there's lots of studies show that that is possible, but it's often confounded by air pollution, meaning that the hottest periods also tend to also have high air pollution levels, particularly ground level ozone, heat exhaustion or heat stroke, uh, kidney functions, electrolyte imbalances. There's actually a lot more adverse mental health consequences, just the ability to keep your own balance. Quite a variety of other systems. Again, part of the reason why extreme heat is sort of underappreciated or counted. Okay, so what can we do about it then? This is a really tricky question, right? Like on an individual level, at your own healthcare practices, right? Once if you have a patient that's suffering from hyperthermia, you know what to do, cool them down and rehydrate. But on a society level, when we have a variety of risk groups, some of those which we don't have really clear solutions for, or there's some clear trade-offs with vested interests, we have things become trickier. So there are things like energy assistance, the low-income heating energy assistance program that helps poor individuals and households pay for electricity, cooling shelters or refuges, or also known as resilience hubs, essentially places. Actually, probably the most common solution by local governments is to open a place that has temporary air conditioning. Obviously, has some lit drawbacks since not everyone can get there. Water, rest, and shade. There is some movement, particularly on the state level, to develop state level standards to protect outdoor workers, and I applaud those 7 or so states that are doing that. The federal level, needless to say, has been quashed. Federal level efforts to do that. Other things like checking on your neighbor, planting trees or green infrastructure, painting your roofs white, and things like this, even partial immersion of your body. So for most of the middle and high income countries, air conditioning is unfortunately our most effective way at the moment to cool people down and prevent heat related illness. But what do we do for people who can't afford that or live in places where they can't afford that? So that there's a really a wide need for low cost, effective solutions, not just globally, but also for those domestically as well, who are poorer. Okay, just pivoting a bit to the solution side. So this is a survey of city governments and people who work on extreme heat or adjacent to extreme heat, a lot of sustainability managers, things like that. And essentially this is essentially what I call sort of a decision-making gap. So the orange bars means that they use it. So there's a variety of sources that they know about and they use. And then there's red, and the red bar says they would like to use it, but they perceive it not to be available. In which here, that's what I'm going to talk about a bit, are both heat vulnerability maps and land surface temperature maps. In which case, in particular, the land surface temperature maps are available, but obviously not easy to use, or people would be using them, easy enough to use. Um, okay, so what are the characteristics of places that experience disproportionately high heat-related illnesses? Just because it's a high-level talk and I want to engage more, I've combined some results from essentially similar studies we've done in New York City, Miami-Dade County, and in Las Vegas, Nevada on extreme heat. So I'm just showing you little snippets of each place, just because what sort of the highlights of how we've engaged in each place. So I am funded by NASA at the moment on their health and air quality science applied science team. So they essentially want people to use their satellite imagery and find societal benefits for it. We found a gap that essentially, going back to that slide about what do planners need, is that they need to know within a city, where is it relatively hotter? So we can get at that with the combination of satellites, some of these other environmental data sets, for example, Microsoft and others, have like a map of every single building in the world. We can combine that with private weather stations. So a normal city, you might only have a few high quality weather stations from NOAA. But these private weather stations Admittedly, they're concentrated in richer areas, but there are a few that are in poor areas as well. Can help us get a better sense of where heat exposures are. So we combine those together using machine learning, and we can get a map of how risk changes over time and over the 24-hour cycle of a day. So here's this Las Vegas for those of you out west. The richer areas, the western parts of Las Vegas, and some of the suburbs there are cooler because they're at a higher elevation. And you sort of see that. You can see the road network sort of pop out during certain times of the day as well. Um, so then switching geographies a bit, we've also worked with New York City. This is from their emergency medical services, looking at classified extreme heat 911 calls. Again, an underreport, but is publicly available and was still of interest to our stakeholders. So here, it's parts of Manhattan clearly stand out. I should note it's a slightly different map than the ones based on emergency department visits, but we can talk about that at a different time. So here, this is actually work I'm just thinking about at the moment. But for me, we've historically had maps based on where people lived, and that hasn't been bad. But for a place like New York City and emergency department visits, I also wanted to think a little bit more about where people are working. So New York City has great data. It has millions of records on where there's street vendor violations. So these are essentially where these are, and this seems to correspond a bit, as well as the number of permits for construction. So my sense is it's a combination of who's outdoors, but now you can actually sort of get some evidence from that from historical records. Obviously, like there's other ways to do this, right? You could work collaboratively with some of their great community groups there. And we can get something like this output. We can say for each degree increase in surface temperatures, how many more, what are our increased risk or odds of having a classified extreme heat emergency call? So then we can start to say if you planted a tree in that neighborhood, sorry, more than one tree, a critical mass of trees in that neighborhood, street trees, what would your anticipated decrease in risk and therefore health benefits be? Okay. Again, an amalgamation of some of the work we've done from different cities. Working with Miami-Dade County and Jane Gilbert, who's here, has been really a treat just because they really wanted to move really quickly on some of our work. And as a scientist, I'm kind of used to putting some interesting ideas out there, but not always having someone who wants to work on it yesterday. So they held a variety of workshops. These were all transcribed and coded according to key themes and engagements on these topics. And some of the outcomes to date, they have over 3 million engagements through a public education campaign. They've worked with people to target some of those risk groups. So it's not just putting it in a random people's social media feeds, but those who are likely to putting on the electronic billboards on bus shelters, on the places where they think we have some evidence people are suffering from extreme heat the most. They started to coordinate the resilience hubs. They tried to pass county level legislation to protect workers from extreme heat. That failed, but I really commend them for trying. One of the benefits of working with a local government is they do still have some things, some of their risks or vulnerabilities they can address relatively quickly. So they are public housing falls under their mandate, and they had 1,700 units. They actually have more than that, but 1,700 units that they weren't going to repurpose or soon, and they automatically installed air conditioning into them. They were able to leverage, at least initially, this grant from the federal government, which was also recently canceled. Okay, right. I mean, whenever I come up with a talk, I hate to end on know what moment we're living in, and right, like I think that's all we can say. But we are not prepared. We have this tree planting grant, which is a really neat grant. It was funded from the Department of Forestry under the USDA, and it essentially waived the match. And if you work with city governments, there's a variety of grants out there, and a lot of them require a match, meaning that the city has to pony up something, or they have to literally coordinate hundreds of volunteers to come up with a match in terms of dollars equivalent for that grant. So they're kind of Herculean efforts. And this one said no, you didn't need a match if you're going to put them all in the most vulnerable communities for extreme heat. So it would have been extremely effective. Uh, this program, where I wrote the brace framework for, is on leave at the moment. The Low-Income Heating Energy Assistance Program, huge. For example, and even in Miami-Dade, it funds about 20,000 households. And so scale that to the rest of the nation, we're talking about hundreds of thousands of households that are losing access to summer cooling funds, disbanding the Centers for Disease Control and Prevention's National Institute of Occupational Safety and Health, or NIOSH, the people who are supposed to enforce and inspect and compliance with extreme heat. Also, huge blows to heat governance. So I think I will leave it there. I apologize. We're a couple minutes shorter than I thought it, but I would be. But I look forward to your questions and comments.
Thank you so much, Dr. Uejio. Very timely and impactful presentation. It really looks at the impact of heat on these communities and the present climate that is intersecting with our work to provide solutions. We want to open this up to questions. You can put those in the chat or you may raise your hand and we will get to as many of those as we can. There is one in the chat about, it's from Dr. Badger, about considering increasing morbidity and changing the danger warning based on this. And Dr. Badger, if I did not explain your question right, if you want to give that question, please do so.
Yeah, some of the recent literature that I've seen has suggested that not only mortality, but morbidity needs to be considered in every city, and depending on where you live, maybe changing the temperature at which you set out heat warnings and institute your heat protocols for the cities. I put a article there, LinkedIn article in my chat, but I'd be curious to see if anybody's started to do that as yet.
Awesome. Great question. Sorry. I'm so excited about I'll respond, but others can respond too. The Yeah, I think New York City might be the poster child. They were able to work with their NOAA's National Weather Service to lower their heat watch warning thresholds to actually correspond to actual human health risks. And somewhat surprisingly, this may like an open secret for most people, but the actual heat warnings for most of the nation, I mean like 98% of the nation, are corresponding just to the most extreme risks. The actual evidence shows when people are actually getting sick is at a much lower heat exposures. So there's sort of like structurally a big challenge there with NOAA. I don't want to like. I think some of those offices are more forward thinking than others. And there was an effort to try to work with that by there was a new heat risk tool that the federal government put out, but I think will no longer be supported this year.
Dr. Fuentes?
Hello, and thank you for your presentation. If My question is, in everything you have studied and everything you have done, if there will be 3 implementations or strategies that you will use that will translate in saving lives, what will that be?
Yeah, wonderful question. Yeah. So no, I think my answer would have normally been Tinge, but let me go with the pre 20. Let me go with the late 2024 answer. But I think some of those I'd have to rethink. So number one, I live in Florida, which didn't expand Medicaid, so expanding access to health insurance number one for me. And so keeping that expansion in today's political climate and supporting Medicaid would be number one still. And then number two, I think before the low-income heating energy assistance program was cut, expanding that support, but also connecting. And this is where I don't know healthcare practices and facilities as well. But my sense is some of the larger networks do have a social services person. But if that could also be included as in sort of like the things that we can help you sign up for, I think that would be really helpful for some of these households. And then from there, yeah, great question. I don't know if we have enough great evidence, but if I had to choose one, like painting roofs white might be helpful in terms of like low cost but effective.
We have a couple of questions so far in the chat. The first one is, given unfortunate federal cuts in building heat resiliency, have you seen examples of private enterprises stepping in, especially as it relates to managing health risks for the vulnerable populations?
I have not. I wish I could say I have, but I have not. Great question though. And they're all great questions.
And if anyone has, please put that in the chat for us. The next question says, I live in Mississippi and work in other states. It seems that the heat in Mississippi is harsh. There are people moving to the state due to new industry. Are they at increased risk more so than the people who have lived here for many years?
That's a wonderful question. I mean, they're all again all wonder. Our knowledge of heat physiology is kind of limited. Like there was some work, some old school work, done in like 60s, 70s, 80s. In some ways, heat physiology has been studied. In some ways, it hasn't been studied that long. And this is those questions. What is the long-term acclimation? How does the human body over relatively longer periods acclimate is not well studied. I think particularly when one moves. So just from talking to folks who work outdoors here, I think it is it is like a multi-year process, if I had to guess, but I can't like prove that on an organelle or cellular level. But yeah, ripe for study.
And if we have any other questions, please put them in the chat or raise your hands. My question is with schools, and you mentioned a bit about schools earlier, and what partnerships need to be built so that we can ensure that our students are best protected and equipped for the heat that we see that's increasing year after year. And also, what policies have you seen? I know you're in one of the hottest states. What policies are being put in place?
Wonderful. Yeah. Awesome questions. Schools are ripe for intervention sites as well. The demographic that has the highest emergency department rates age-wise is teenagers. And I suspect it's largely youth sports. And a second would be sort of teenagers working outdoors. But yeah, and so Jenny Vanas, who happens to be married to Dave Handula, but Jerry is an awesome scientist in her own right in Arizona State University. And others, Shortridge, have developed like a heat ready schools checklist that I'll have to maybe send to folks afterwards. But one can look into that, looks into this strategies, where that's sort of timing and education. And certainly like from a bigger picture perspective, working with places like Miami-Dade, they know that cities actually are one of the places, the schools are one of the places they could intervene on in a few ways. It's also land where they could plant trees, potentially, and also cool down that population. Another one that's perhaps worth mentioning is the Corey Stringer Foundation, which some of you may be familiar with. Corey Stringer was a pro football player who died of exertional heat stress. But Doug Casas and his team there and others they do a scorecard for each state, saying how good is your state at protecting high school athletes. They did focus initially on football, but at those guidelines are, I think, more widely applicable. So I guess I'll just speak for Florida. Specifically, there's a high school athlete, Zach Martin, who died in one of these cases, the heat wasn't particularly high for Florida, but when you're starting to play football in the heat of the day, and sort of like the training camp periods, died from exertional heat stroke. And then Florida High School Athletic Association was sued, but did eventually pass one of the stricter standards in the nation that requires you to like have a monitor to see how hot it is, requires you to have an athletic trainer, things like that on site. So it'd be nice, but I'm not sure if I think there's still quite a few states that don't do that at the high school level. And then if I have concerns next, it would be the middle school level for things like club football, some of these other sports.
There are a couple more questions. Dr. Savary, are you able to pose the question? I can also read it for you.
I don't think you want me to unmute.
Okay, so his question was talking about a frame shift. So in other words, not selling the detriment of heat, but the cost of addressing the consequence. So for one emergency department visit for a heat stroke costs X amount of dollars, and proactively making resilience centers. So thinking about the way we communicate the cost of heat.
Yeah, awesome point. I agree. I mean, I think both sometimes being too focused on health does lead me to the sort of that frame. A heat-related emergency department visit anywhere from like 3,500 to 5,000, hospitalization 10 to 12, $15,000. So yeah, I guess the it's sort of like who ends up paying for it, like there is, I think, an argument to weigh if our, obviously you folks know better than I do, if our system incentivizes prevention versus treatment. But that being said, I think that is the way forward. Whether there is one construction group in Miami-Dade that, for example, wanted to. The politics are a little bit more complicated than this, but wanted to proactively implement some of these heat protections that were proposed. And I think recognizing and shining a light on those, evaluating them is potentially a way to go in sort of today's climate.
Great, and I think we have one last question for you. In your experience working with health departments to implement the BRACE framework, what have been the most effective strategies for translating climate data into actionable public health interventions, especially in those communities with limited resources?
Thanks, Dr. Williams. Awesome question. So, like on one hand, yes. I mean, I think I think race has a lot that it can stand on. I mean, I think the extreme heat, if I had to like choose something, of all the 16 or so states and jurisdictions I showed you, the number that would have had an extreme heat response plan if there was no brace would be much less. And I know that's hard to have a counterfactual for that, but the fact that we even have written plans for heat data streams, local connections, um, work with community-based organizations. And I know that's sometimes like hard to argue. For example, during the Pacific Northwest heat dome in the early 2020s, that Oregon was relatively well prepared, and so was Washington. Not prepared enough, but it would have been much worse, which if they weren't funded. And that's kind of hard to argue because you get it from both ends of the. If you're effective, no one dies and you don't get credit. If you're not quite effective enough. Anyway, yeah. So I'd say heat, New York City, Be a Betty program, not lowering the heat warning thresholds in New York City. They've also worked with their electricity providers to provide a backup utility, enough grid power for their poorest neighborhoods. There's a variety of things like that. There's other states that I would point to like that, like Arizona and Maricopa County, that's actually trying to lower their adverse health outcomes. To be honest, it takes like a decade, I think, before you can start to bend some of that health outcomes, which is why it's tough to have it disrupted. But great questions.
So I do have one more, and it's kind of a two-part one. What advice would you give to emerging researchers who want to contribute to applied public health solutions in the climate and health space, and how can we strengthen the collaborations between academic institutions, public health agencies, and frontline communities for more impactful efforts?
Yeah, I mean, I think this is like a test moment for everyone. I'll speak for academia because I think I should be critical of them because I'll speak for them because I come from them, and I'll criticize them too. I think this is a moment for academia to show if it was committed. And I think to this, not just, well, I mean, it's just this enterprise of addressing climate health and equity, but also the enterprise of the movement towards working more with community-based organizations. And to be honest, some of them, many of them, right, were not, right? Like they just thought that maybe that's a buzzword or maybe that I can leverage something. But within those universities, there are researchers who are. And I think that's where it's up to the researchers to still like say, hey, if we can, as much as we can, still provide some funds to some of our community partners, we got to work together to survive this sort of period. Yeah, and then in an ideal world, right, I think there is a movement towards having the community partners with like experts on this call, others who have some of the technical expertise, at least initially, co-design interventions that are actually within communities. Like I think we don't want to abscond that to a lab. We don't want to say, in my opinion, some of these people disagree with me, which is fine, but my instinct isn't necessarily like randomized control trial for air conditioning first. It's more to like, yes, we know we have a sufficient amount of evidence. How do we actually deploy that in a sustainable way? And that has to be on the more the community side than on the academic side.
Thank you so much, Dr. Uejio. This has been a very informative webinar, and we appreciate you sharing your expertise. And thank you to all of you for participating in this series. I hope that you found it useful. As a reminder, they are held on the second Friday of the month, and our next webinar is on May 9th at the same time, and it will be on the topic of extreme weather. Before you leave, we ask you to take a moment to complete the webinar survey. If you haven't already, the link is in the chat. And this now concludes our session. Have a wonderful day and a great weekend.